Welcome everyone to the September 8th, 2020 COVID-19 clinical rounds on critical care. My name is Richard Hunt. I'm an emergency physician who serves as senior medical advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer real-time sharing of COVID-19 critical care challenges and successes. If I'm a clinician caring for COVID patients, the clinicians I want to learn from are those clinicians with the most experience. This is a voluntary public-private collaboration, thanks to the multiple professional organizations who have collaborated on the rounds. They are not intended to be redundant or replace any organization's initiatives. They are intended to be sharing of clinical experience, not recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on clinicians sharing their successes and challenges with other clinicians. Thanks to the National Emerging Special Pathogen Training and Education Center, NETEC, for their support with these rounds. NETEC has webinars that complement these Project ECHO COVID-19 clinical rounds. Thanks to Project ECHO, Dr. Bruce Streminger and his great team for the peer-to-peer learning platform we're using for these rounds. Upcoming ECHO COVID-19 rounds currently are all US noon Eastern time. This Thursday, September 10th, will be emergency department rounds, patient care and clinical operations, focused on Alaska's emergency departments. Frequently, we have participants from rural and frontier areas participating on the rounds, and it's important to address those challenges as well as the urban areas. Next week, we will have our usual schedule: Monday EMS, Tuesday critical care, and Thursday emergency department. Stay tuned for announcements for future rounds. We'll work to continue to identify topics for these peer-to-peer learning rounds that are most timely and helpful to clinicians. Project ECHO COVID-19 clinical rounds have included participants from over 100 countries and all United States states. As of September 3rd, Project ECHO COVID-19 clinical rounds have had over 32,000 cumulative participants and over 8,000 video views. Answer all the questions we receive in advance of the rounds, but we do pick out major themes from questions received and hope to cover some of those. Dr. Streminger will now go over logistics, please.
Thank you, Rick, and welcome to Dr. Ivor Douglas from Denver Health. Thanks for joining us today, and to Vikram and Bruce Ribner, our expert panelists who join us regularly. And most importantly, thanks to all the participants for tuning in today. I've got a couple of housekeeping items and logistic items to review as we do each session. Just a reminder that we really appreciate your questions and comments, and there's a Q&A button at the bottom of the Zoom toolbar. So please put your questions and comments regarding today's presentation there. We'll be monitoring that area. If you've got any technical or logistic issues, please put questions or comments related to that in the chat function. And also, Rick will be asking a crowdsourcing question in a minute or two, and please put your response to that question in the chat. We are recording the session, and your attendance is consent to be recorded, so thank you for that. Today's presentation is linked to the email announcement from Project ECHO that went out this morning, so you should be able to access through a hyperlink Ivor's presentation he'll be giving in a moment. It will also be on our website in a day or two, along with a link to the recording of today's session, and we'll share a link to that in the chat as well. There will be CME and continuing professional development credits offered through the University of New Mexico, where Project ECHO is based. About 15 minutes before the end of today's session, we'll put a link to the CME survey, and when you complete that, you will get instant electronic CME. There should also be a link in today's email announcement, and the link is good for 48 hours. Just as a reminder, these learning sessions are focused on improving patient care and health systems and supporting clinicians. So we want to keep these political and commercial free zone, and we thank you for that. Just a note about data use, the data that you share with us when you register, when you answer the polling questions, when you put comments in the chat, we really take stewardship of your data seriously, and we just want to just let you know that we're doing everything to keep it safe. And we do share de-identified data with Rick and Asper for reports and maps and things like that, but otherwise it is kept very locked up. Now I want to hand the microphone over to Dr. Bruce Ribner at Emory with the NETEC Center to talk about NETEC's education and training initiatives. Bruce.
Thank you, Rick and Bruce. I'm Dr. Bruce Ribner, one of the principal investigators for NETEC. And as Dr. Hunt mentioned, we are running a complimentary series of webinars. Esper can't do everything. And so coming up, we have on September 18th, a webinar on palliative care. On September 25th, we will be having a webinar on the epidemiology and treatment of COVID-19. And on October 2nd, an area that is always highly subscribed, personal protective equipment. You can find further information on these programs, registration information, as well as access to previous webinars that we've done, which are now, you can listen and stream at your convenience, all at our NETEC website, which is netec.org. Thank you.
Great, thanks, Bruce. And we just want to remind everyone that the AAMC is a collaborating partner in these clinical rounds, and they've been developing a COVID-19 clinical guidance repository since March, and it's updated every week, and it's really a very rich resource of information and guidance, and we encourage you to check that out. And with that, Rick, I'm going to hand it back to you for the crowdsourcing question.
Thanks, Bruce. Over the past probably a couple months, increasingly we've had discussions on rounds, whether it's the critical care, EMS, or emergency department series. Participants in the chat, but also speakers and panelists have commented on our challenges with fatigue and complacency. And so it struck me that it would be important to find out what we're actually doing about it. It's a real challenge for all of us. And so the crowdsourced question, and hopefully like some of the other questions we've had where we've had some like really like, wow, had no idea that was going on, and people took up that specific cause or issue. What specific steps has your organization taken to fight complacency? What specific steps has your organization taken to fight complacency? I'd like to now get back to the Hollywood Squares, and if Bruce and Vikram could go off mute, and if you could introduce yourself with your name, title, and affiliation. I'll start with Bruce. Why don't we go ahead with you first, and then all over to Vikram.
Thank you, Rick. I'm Dr. Bruce Ribner. I'm a member of the Infectious Disease Division at Emory University in Atlanta, Georgia. I'm also principal investigator for the National Emergent Special Pathogen Training and Education Center. Here today representing NETEC as supporting organization for these webinars.
Thanks, Bruce. Vikram.
Thanks, Rick. Hi, everyone. My name is Vikram Mukherjee. I am an intensive care physician out of Bellevue Hospital in New York, where I serve as the director of the medical ICU. I also serve as the director of our special pathogens program, and thank you for having me on these rounds.
Thanks, Vikram. Thanks, Bruce. It's an honor to turn this over to our speaker for today, Ivor Douglas. Dr. Douglas is Chief of Pulmonary Sciences and Critical Care Medicine and Director of Medical Intensive Care at Denver Health. He's also a professor at the University of Colorado, Denver Department of Medicine. So welcome, Ivor, and look forward to your presentation. Thanks.
There we go. Good morning. Can you all hear me? It's a pleasure to join you. Thank you very much to NETEC, to ASPR, and to Project ECHO for the invitation to join you this morning. I think this is a remarkable resource, and I think an opportunity for a discussion around areas that have emerged rapidly as either usual care practice without substantive evidence base or a lot of variation in care. And I want to focus specifically today on a case that I hope will be sufficiently provocative to get a good discussion going. So I'm going to focus on the question of prone position care during mechanical ventilation. And as you'll note, I have no specific conflicts of interest to report relative to this presentation. Let me just advance my slides here. I'm going to just stop sharing for a second and come back on. There we go. All right, let's see if this gets the job done. So I'm going to briefly review a case of a 68-year-old Mexican national who had been in Denver for so many years, who presented with a 5-day prodrome, highly prototypical of what turned out to be COVID-19. This is not a diagnostic dilemma. He has a COVID test PCR positive on emergency room presentation. And his specific risks pertinent to the presentation is that he has clear metabolic syndrome, a BMI of 34, type 2 diabetes, which was not well controlled, hypertension and hyperlipidemia. And his early course is notable for care on our general COVID floor using self-proning. I'm not going to speak much about that today, but happy to discuss in the open session for about 5 days. And despite this, he developed progressive acute respiratory distress syndrome and sepsis and was intubated on the 14th day of hospitalization. His primary inflammatory characteristics of his disease, in addition to this X-ray, which demonstrates the subpleural predominant and basal airspace infiltrates, were those of septic coagulopathy and a very profound shutdown of fibrinolysis, a very prototypic aspect of COVID-19. And in terms of his risk prognostication, his interleukin-6 level of admission was 181, and in large meta-analysis, a threshold cutoff of 80 picograms is associated with significantly increased risk of mortality. So if you put that in combination with a peak C-reactive protein and a peak ferritin, almost 1,500, this was a patient who was entering the intensive care at very high risk of death and with a very severe inflammatory and septic coagulopathy disorder. So his course was notable for the following cares. In addition to intubation mechanical ventilation with lung protective settings, he received treatments for COVID, which at the time were real cutting edge. Boy, doesn't a couple of months make a difference. Azithromycin hydroxychloroquine. Our study has recently demonstrated, in addition to others, that that is not of therapeutic benefit. He was randomized in the tocilizumab versus placebo study. Our manuscript of that is currently in review. The early press release shows no clinical benefit. And he was treated on a ventilator with neuromuscular blockade and vasopressors. Notably, because he was admitted in April, he did not receive remdesivir. We were paranoid about the use of steroids, and we didn't have access to convalescent plasma. And again, boy, doesn't a couple of months make a difference. He was very sick on his initial ICU admission with a SOFA of 4 going up to 9, a maximum SOFA score. This is sequential organ failure assessment score, very useful to get a quick handle on how severe organ failures are in septic respiratory failure. And he was initiated once prone within about 8 hours on prone position ventilation. And this was performed not for the standard 17 or 18 hours a day with a return to supine position, but for prolonged periods. Indeed, the first of his 3 episodes of prone position was 3 1/3 days without return to supine. And he spent fully a quarter of his total mechanical ventilated days in the supine position. His ICU length of stay ended up being 54 days. He was in the hospital 78 days, and he survived to transfer to rehabilitation. This despite the accumulation of a spectrum of organ failures and complications. He experienced a cardiac arrest, which was around the 16th of May. You can see on this time sequence at the bottom. This was related to a mucus plug and hypoxia, and he was shortly thereafter tracheotomized. And what you'll note is that between the initiation of ventilation and first prone, he spent the full part of 2/3 of a month in the prone position. He achieved ventilator independence in June and was discharged in late June. And without going through the agony of all these complications, I think it's very clear that there's a substantive burden of comorbidity. So I just want to contextualize the evolution of this gentleman's disease. And what you'll appreciate is the extent of his early ARDS. And one of the things I want to really highlight is that this is ARDS. It has some rather unique pathophysiologic and pathogenic features, but it's ARDS. And its resolution by the middle of June prior to transfer was actually with evidence of some fibroproliferative change. And he's got the subpleural residual traction bronchiectasis and these small cysts indicative that he may well have a chronic lung disorder complicating his disorder. So I want to just spend now a few minutes reviewing the cares of acute respiratory distress syndrome and put in context where prone position fits, and more particularly prolonged prone position in ARDS from COVID-19. There's a spectrum of cares that we apply for conventional septic ARDS that fall into the rubric of lung protective ventilation. And at many places, prone position is not considered an early intervention, though our practice, and has been for the last 15 years, early, meaning as soon as the patient has a saturation that is not sustainable above 92% with an FiO2 of 60% or more and PEEP of 10, is a usual care standard of practice. Corticosteroids are controversial. We have an ECMO program, but use it infrequently, and we initiate early aggressive weaning. Well, how does that contrast with what we're learning about COVID-19? We are working very hard to individualize care around the use of minimally invasive oxygen support and conscious proning. We do initiate lung protective ventilation, but use a much higher amount of positive end expiratory pressure than we often do in conventional ARDS. And again, we initiate prone position very, very early. And because of challenges related to access to the patient PPE, and some evidence from our group and others that there is no benefit in supining the patients, we initiate prolonged periods of prone position ventilation. And in the period that I've been given this talk, 5 months, which I've probably given this talk close to 25 times, corticosteroids went from contraindicated to now indicated, and you'll see that that's the evolution of the field. Well, the argument that I will make is that prone position is readily accomplishable in most ICUs and without specialized equipment. Training programs that we have with our providers allow for ready delivery of prone position with 4 or 5 bedside providers, specific positioning called the swimming position, and we've published some of this work before. Without spending a lot of time on the pathogenesis or pathophysiology, let's remind ourselves that in randomized control trial, prone position ventilation is associated with a reduction in mortality, 16% absolute risk reduction in the PROCEVA study, and that's been validated in meta-analysis. It improves PF ratio, but its benefit is not through optimization of oxygenation alone. It's through reduction of lung regional injury and improvements to other recruitment strategies. And this is really because of improvements in the dorsobasal recruitment of the lung, improving VQ mismatch when a patient is turned from the supine to the prone position with a reduction of injurious overdistension of the dorsobasal part of the lung. The problem is that prone is not being routinely used in any patients, but in COVID patients specifically. So if you just look at the impact of prone position ventilation, it significantly reduces mortality, perhaps as much as 16%. But even in recent point prevalence studies, in the most severe patients, no more than 1/3 and sometimes fewer than 20% of patients receive any level of prone position ventilation. In this systematic review that we have in review currently, we looked at the use of prone position ventilation in adult and pediatric ICUs and demonstrated that the highest use was amongst 19 patients in San Francisco, but on average, you're looking at fewer than a third of patients receiving any level or period of time of prone position ventilation, despite the evidence of its benefit. So we just have in review currently a outcomes retrospective analysis from a prospective cohort that we've developed, where we looked at the impact of prolonged prone position ventilation, not for efficacy, but for safety in our COVID-19 patients. And we're particularly interested in ulcers, rates of injury, and secondary outcomes. And so without going into too much detail, we looked at all of our SARS-CoV ventilated patients between middle of March and end of May. The ones that met our criteria for usual care implementation of prone position ventilation were 61 patients, and we excluded 26 who rapidly stabilized before prone. And of those 61, 42 survived and 19 died in the ICU. 23 of those 42 were ultimately sent home liberated, and 8 were in the hospital when we completed our report, but liberated from ventilation. So I want to show you just lastly a couple of data slides relating to the impact of prone position ventilation and some safety questions about its use for prolonged periods. So these patients in general received prone within a third of a day, received at least 3 days for their first prone period of ventilation, were profoundly hypoxemic, had relatively compliant, this driving pressure is a low number, compliant lung mechanics at the time of initiation. And what was impressive was that there was a significant difference between the median day 0 and day 3 oxygenation measurement, PF ratio, in those that survived, but not those that died, suggesting that there was a almost valuable predictive utility in your initial response to prone position ventilation. These patients spent a third of their total ventilated time in the prone position, and the majority of them received at least 2 and sometimes 3 periods of prolonged prone position. Secondary outcomes I've discussed already. So safety is the final point. Many of these patients develop edema of a moderate variety, grade 2 and 3. Wounds were common but minor, grade 1 to 2. And as I'll show you, the incidence of severe wounds was actually rather infrequent. That said, there was a good number of patients with hospital-acquired infections. A third developed mucus plugs. About 18% needed some level of escalation with airway clearance or re-intubation. And a lot of patients had to have tube repositioning around their prone position care. Many patients, almost all patients, developed some level of critical illness neuromyopathy in the course of their care. But only a limited number, 5 of all these patients, had some measurable brachial plexus injury related to their positioning, and all 5 of these had a body mass index of 35 or greater. We had only 2 patients develop a grade 4 pressure wounds, and the more minor wounds, such as these, were, as I mentioned, quite common. So taken together, this is a case that I think is supported by a retrospective series that would strongly suggest that the safety profile for prolonged prone position in these patients is acceptable, if not perfect, that the mortality rates that we're seeing are on the lower end of the spectrum compared to those reported for severe ARDS from COVID-19, and that the ability to perform prolonged prone position ventilation is entirely feasible without the necessity of specialized equipment. And so with that, I'm going to turn back to our moderators and take some questions or discussion. I thank you very much.
Hey, thanks very much, Ivor. That was a great presentation. The slides were great, and particularly like the one with the swimming position as opposed to, I don't know how much that other contraption cost, but it was a lot. So Ivor, a question, and then I'm going to open it up to Vikram and Bruce for their questions, comments. Ivor, so the ET tube, endotracheal tube reposition, to me, when I look at, okay, so you got them on intubated already, and then you're going to prone them, it's intuitively obvious that you got, to me, that you got to reposition. Is it predictable exactly how you have to reposition it? Really, you have to wait until the patient is prone and then make fine tuning adjustments? Or is it like, okay, we're going to reposition on the front end first? Yeah, it's just pure mechanics.
It is, but I thank you for asking a incisive and very important question. The real challenge in this specific population of COVID-19 patients versus our regular ARDS patients is that body habitus, particularly upper thoracic neck positioning, is such that it's very difficult to predict once you reposition the head in that swimming position, the extent to which the tube may either be pulled up or down. We've actually looked at this, trying to look at neck measurements to try to predict this, and we've looked at regression curves, and we looked at band Altman plots to see if we can determine this non-invasively. We cannot. And it is actually quite remarkable the amount of creep that an endotracheal tube can have with simple repositioning. So our practice is an intermittent chest X-ray with an estimation of proximity of the tip of the endotracheal tube to the carina. The real challenge in these patients is we're trying not to do X-rays on them. We're trying to minimize exposure. And so I think that is a very important area that needs continued reconsideration. There has been discussion of trying to use a locator beam or other strategies, but this is not accessible to ultrasound. And so it really continues to be a significant area of challenge. The reason I'm so sensitive to this is that tube displacement and serious complication, it was seen occasionally in this patient population. And those in people who are getting intensive monitoring and care. So I really do emphasize that is a key issue.
No, thank you. Thanks, Ivar. Vikram or Bruce, raise your hand. Whoever's first. Vikram, you went off first, so go for it.
Sure. Thanks, Rick. And Ivar, a wonderful presentation. Thank you for such a succinct presentation. A few things that I would just like to mention. The complications you mentioned, the mucus plug and the fore extremity weakness, would probably have happened even without the prone positioning. These are consequences, at least in my experience, from the neuromuscular blockage that the patients often receive. And COVID itself, at least in New York, had caused such a high degree of secretions that our ET tubes were getting clogged up even without prone positioning. The second question, the comment I had is you bring up an important point of how important it is to prone, and despite solid evidence, our institutions don't do a great job, 16 to 20%. And I'd like to remind our colleagues here that very few patients with ARDS will actually die of hypoxia, and we should not wait for a patient to be in refractory hypoxia before we initiate proning in them. From the ARDS trial, we know that only 16 to 17% of patients with ARDS will die of hypoxic failure. And most other patients will die of multi-organ failure from worsening vent-induced lung injury. The third thing that I'd like to mention, as you saw in this patient, the patient had a cardiac arrest. Thankfully, he was supinated by that time. But if you have an active proning protocol, you should account for how you would handle a cardiac arrest in the prone position and develop protocols around it. There is some information on the AHA websites on how to approach this, but just be prepared that if you have a large volume of patients who are proning, there are chances that someone might have an arrest in a prone position. Thank you.
Dr. Mukherjee, thank you. Those are really three crucial points. I cannot emphasize enough the issue that prone use of bailout or rescue therapy is guaranteed to be ineffective. There's a whole lot of discussion for another day about predicting responsiveness or recruitability to prone, and more complicated than today's discussion. But just this notion that at least giving it early consideration is crucial, I cannot emphasize enough. We and others have developed training protocols that we'd be more than happy to share if people want to contact us. And then lastly, I think this issue is of realizing that prone position is really part of a broader lung protective ventilation strategy. There's virtually no benefit of adding prone position unless you're also doing the kinds of low tidal volume careful PEEP management that would be usual care standard.
Thanks, and Ivor. Bruce, yes, please.
Yeah, sorry. Dr. Douglas, excellent presentation. I know your study was primarily about ICU ventilated patients, but we're increasingly seeing data on non-ventilated patients being prone. And you emphasized early proning is really critical for the ventilated patient. I wonder if you would be able to comment on proning even before patients require ventilation.
Dr. Ribner, thank you. That's a wonderful setup. I was hoping you would ask the question. I would like to, if I may, if I could potentially just bring up one extra slide just to highlight this comment. And this is, I hope this will be okay. I'm not overstepping the bounds here. So I just want to highlight what we're doing prior to requiring either intubation or other forms of non-invasive ventilation. And that is very early on initiating this process of cycling repositioning. And I need to emphasize, it's more than just proning. It's this lie on your belly, lie on your side, sit up, lie on your side, go on your belly. And this strategy, which is either termed conscious or weight proning, unquestionably is associated with enhancements, as you'll see on this nice review from Thompson, or actually case series from Thompson, in the saturation for patients who are receiving this therapy. I need to say with great care and caution that both in our experience and in the published literature thus far, the case is still to be made that this either delays, defers, or avoids progressive ARDS or need for intubation in these patients. We and others are looking prospectively at this. I think that there continues to be value, and of the 180 something patients I've had with severe ARDS in my ICU, just two of them thus far have managed to make it all the way through their 3 or 4 week course with intermittent self-proning and positioning, plus supplemental oxygen or non-invasive ventilation. It is not to dispute the physiologic effect, it's to question whether ultimately this is changing the natural history of the disease. And my hunch is no, but I'm open to being convinced otherwise.
Thanks, Bruce and Ivor. There's a couple of questions from participants. One, I'm just going to read it, Ivor. On the posterior lung CT near discharge highlights the fibrotic lung damage. On the one shown, it looked like these were in the posterior lung areas. Have you observed differences in recovering residual lung areas between prone and non-prone or less prone patients?
I'm just going to reshare the image.
Sure.
Dr. Hunt, you can see that, correct? You can see the image, right? So the point that the questioner is making is that you get this dorsobasal, posterobasal involvement in what appears to be microcystic and traction bronchiectasis that seems to be highly indicative of a fibroproliferative form of the disease. And the questioner asks a very legitimate question: if this patient spent almost a third of their total ventilation time in the prone position, where presumably you're reducing cyclic lung stress and strain and torsion effects or the mechanical effects on that dorsobasal lung, why on earth is that not alleviating the progression of fibroproliferative disease in that dorsobasal lung? So it's an unanswerable question presently for several very valid reasons. One, we just are unable to perform regular CT. In fact, this patient was, this initial CT was obtained with a question of a pulmonary embolism very early on. This was obtained post-extubation to evaluate residual lung fibrosis. There was not a single CT image performed between these 2 points explicitly to reduce risk of aerosolization or having to mobilize a patient who's shedding. Now, that's a real limitation to this question. However, we do have some interesting data from non-COVID ARDS, and that is looking at the effect of prone position ventilation on lung regional stress strain and injury in patients, let's say, with pneumococcal pneumonia or pancreatitis or other things. And indeed, there is some quite compelling reason to believe that there is a modification. So my answer to the question would be, boy, I wonder if the injury and fibrosis would have been even worse had we not put that patient in the prone position. We had thought that the disease fibroproliferative ARDS, the late phase of ARDS, had gone away completely. In fact, I'll be honest with you, in the last 20 years, we've seen a significant reduction in that disease. But I do seriously believe that COVID-19 will create a new opportunity for us to reconsider this reorganizing phase of late phase ARDS, not just because of the severity and prolongation of care, but because there may well be a pathogenic mechanism for fibrosis in the lung of these patients.
Thanks. Another question that came up, and before I ask the question, it speaks to the challenges with nursing care. And as I've listened to Ivor, your presentation and those of your colleagues who are intensivists, it's very clear the nursing challenges in ICU are really profound. And toward that end, next Tuesday's critical care rounds, we're going to have critical care nursing presentation to really try to get, and we have a large number of participants, across the board, EMS, critical care, emergency department, a lot of nurses, EMTs, paramedics, intensivists. So want to get to that. But there's a specific question about nursing. The low incidence of sores wounds and by the way, this is the first time I've seen that data on our rounds anyway. The low incidence suggests excellent nursing care. Are there special procedures that you can share with us to prevent pressure wounds and similar problems in prone patients? And obviously you think about like the whole pressure sores and the approach to it. Is there something unique about COVID and proning around pressure sores that you can share with us?
Yes, I will start my response by giving abundant credit to really magnificent staff. I rarely go in and physically assist in proning a patient. I talk about it a lot. The folks at the bedside do a phenomenal job and have really got this down to a legitimate science. Dr. Hunt, if you wouldn't mind, I'm going to just play a 30-second clip of a video, if that would be acceptable. Just to make a point here about how,
give it a try.
About how very, let's see if this will work. And you may not be able to hear the sound, but you almost certainly will be able to see the video. Let me show you just how important positioning and proning is. So this is our crack team. They're called the Bebop team, the best practices of proning team. And Andy and our outstanding group here are going through the process of preparing a patient for manual proning. And you'll see on the left-hand side that they have some specific wedges prepared. They've done a lot of preparation. I didn't take you through the prone step itself, but I do want you to look at the specific positioning to swim this patient and to actually position the head with specific foam and positioning the legs so that it's carefully cradled and nestled. And then covering it all to make certain that the patient is optimally protected. I cannot emphasize that this is an expert team, but this can be done with minimal training. This is an 8-minute video to optimize care delivery in every ICU in this country. I do want to emphasize one last thing. I remain to be convinced that the swimming position is a safe intervention in patients with very high BMI. The patients that developed brachial plexus palsy like this, I don't think that under a regular day they would ever lift their arms above their shoulders. So to take somebody with a BMI of 50 and put their arm above their head and leave it there for 2 hours and then do this for 2 hours is not just non-anatomic, it's non-physiologic. And so I remain to be convinced, and in fact, we're rethinking this a little bit about whether in those high BMI patients, we should actually modify our standard protocol. I hope that responded well.
No, that's great. The video was great, actually. Before I want to do the polling, but I want to do sort of a lightning round with with the three of you, Ivor, Vikram, and Bruce, and this is just a show of hands. And Ivor, I loved your the steroids, cross it out, and back and forth. So today, if each of you were treating the same patient that Ivor presented, would you be using remdesivir steroids and convalescent plasma on that patient today, realizing the only data you have is what Ivor presented? Just show of hands.
Not convalescent plasma, Rick, but remdesivir and steroids.
Okay, all right, that's fair. No, that's fair.
I agree with Vikram. Certainly remdesivir early on in his hospitalization, and certainly steroids as his oxygenation was deteriorating and while he was on the vent. I remain to be convinced about convalescent serum.
I clearly should have rephrased the question. Ivor, you would have done the same as Bruce and Vikram or something different?
Yeah, I would have certainly considered remdesivir and steroids. And again, in full disclosure, Connie Price, who's our emerging infectious disease lead at Denver Health, and the issue of steroids, because of our MERS and SARS-CoV initial experience, left us very trigger shy in terms of steroid treatment. And I would say we were late adopters, not early adopters. I will tell you that having spent a tremendous amount of time around the CP, the convalescent plasma question, and thinking about how to develop the bank and looking very carefully at the Mayo Clinic data, and also more importantly, looking at the safety data, in those first 10 days of the illness, I would have given quite serious consideration, even considering the inadequacy of the prospective validation data, to administering convalescent serum to this patient. Why? Oh, we would have given tocilizumab, we would have given him hydroxychloroquine, and I think that we need to be very cautious about how we deploy extraordinary care during a pandemic. This has been referred to in several publications as pandemic exceptionalism. I find that a particularly important way to frame this. I definitely think that as care providers at the bedside, there is an imperative to provide usual care standard practice. There is an imperative to consider potentially useful therapy in gravely ill patients with this consideration. You've got to define what is termed the warrant for care. Is this patient circumstance specific enough to provide sufficient justification based on lower level evidence where the risk benefit favors an intervention? And for that reason, I would not have ruled out convalescent plasma. I'd love to have done a prospective study, but I think I might have given it serious consideration.
Thanks. There's one more topic. There's so much to talk about. One more topic. I want to make sure that each of you have like a couple of sentence responses to this one for each of the three of you. And some really brief background. Within hours of the story on bradykinin popping, a former director for medical preparedness policy from National Security Council shared with me that the bradykinin article related to the supercomputer analysis. And then like an hour later, a friend of mine from college says, well, I live 23 miles from that computer. So obviously it caught a lot of people's attention, the bradykinin article. And I'd be interested to hear, realizing it's a supercomputer analysis, your thoughts on the bradykinin article at this point in time, realizing we got a computer analysis and that's where we are. So Vikram, then Bruce, then Ivor. Vikram.
Thanks, Rick. It's interesting, big data being analyzed by a supercomputer. I think at best, it will be hypothesis generating. And in my mind, nothing more than that.
Thanks. Bruce?
I'll share, I'll second Vikram's comments. Leads like this lead us to do studies, but that's all I'm willing to accept at the present time.
Great. And Ivor?
We're conducting a study at the moment with Roche looking at the ST2 IL-33 receptor pathway that directly regulates bradykinin pathway production. I think it's a quite feasible mechanistic hypothesis. It sort of got back-ended through a big data analysis, but if you actually look at the evolution of this illness in terms of systemic inflammatory response. I think it's definitely a testable target, and I think that you'll see that this will become one of the biologic targets of the active network's next trial in immunologics. And so I agree. I think Dr. Mukherjee is spot on. It's a great hypothesis to target, and I think their study is doing it right now.
Yeah, and one of the things I think actually has been, and Amanda, Amy, and Bruce, we're going to go to polling after I make this quick comment here. One of the things I think has been a valuable part of our rounds is people, our participants, speakers and panelists, see that whatever it is that pops in the news. And I think one of the roles that particularly our speakers and presenters have really stepped up to the plate with is tempering what the next best thing is. And that's proved to be an important function, I think, of the round. So I really appreciate your comments on that. So we're on the polls. These are pretty straightforward questions. There's a couple on proning. And then there are a couple on some of our challenges with fatigue, complacency, et cetera, et cetera. So these are a little bit more straightforward than some of the ones we had last week. So let's put up the first polling question. Okay, in your healthcare facility, approximately what % of COVID-19 critically ill patients have been proned? And it says healthcare facilities, so they gotta be in a facility. For those of you, and then for each of these, you know, if it doesn't apply to you, as in I don't work at a healthcare facility, there's the option for you too. Participants have gotten really just increasingly great at responding quickly on these, and really appreciate your participation. Got about 42%. We'll give it another probably 10 seconds or so. And then for those of you who are EMS providers, this next one is for you, okay? So this is healthcare facility. Next one is going to be for EMS providers. Ivor, a lot of appreciation in the chat for your presentation. Just want to recognize, I appreciate it, but a lot of other
That's
people.
very generous.
All right, let's stop there.
Very generous, thank you.
53% of you voted. And Ivor, these polls, you know, they're not double-blind controlled studies. We got that. So, yeah, it looks like 1 to 24% was the most frequent response for those of you who were doing prone at healthcare facilities. And interestingly, to me, it's very interesting, participants, our organization hasn't seen a COVID-19 patient, 9%, 1 out of 10 of you. Unlike some other facilities, what do you think, Vikram? All right, next. This is for EMS organizations, okay? And there's the option if you don't work in an EMS organization. But proning has been a topic that's sort of been a little bit of a roller coaster ride when it comes to EMS. It'll be interesting to see about EMS and their proning. For those of you who haven't seen it, there's a I don't work in an EMS organization response there too. Another 10 seconds. All right, let's see the results. 55% of you voted. Thank you for those of you who voted. So it looks like the most frequent response in the percentages was 0%, 20%, but then 1 to 24% at 10%. So clearly there's some proning that's going on out there. Yeah. All right.
Dr. Hunt, could we ask folks in the Q&A just to indicate on the chat if they don't prone, is it either because they're unaware of the effect or there's some logistic aspect?
Yeah. Bruce and Amy and Amanda, can you try that question out there?
Well, I think, Rick, well, you know, Ivor, those are EMS pre-hospital. I think most people in ambulances probably aren't proning patients. And
Right.
that actually,
Should we ask in the chat for them to indicate either do they know about it or just that they don't?
Yeah. So, I mean, the question is, do EMS providers know about proning? Yeah.
and one of our EMS providers put in the chat earlier, should we be proning patients in ambulances en route to the hospital? And that is a question I think they'd like to hear your thoughts on. Is that something they should even be considering? At an earlier discussion about this, I think, anyway, I think it'd be great to hear your thoughts on that.
Yeah. Ivor, go ahead and let's talk about that now. We can pause the polling. And by the way, a lot of people are already responding to that question over there. Yeah. So Ivor, yeah, your thoughts about EMS and the proning. What do you think?
I think that there should be every effort to try this. I totally understand if you're in a fixed wing or in a helicopter transport, that's going to be very challenging. But in a road transport, even 15 or 20 minutes, if it would obviate the need for point of care or field intubation to deliver some non-invasive ventilation or oxygenation in the prone position, it's something that should be considered. I certainly don't have evidence that it's better, but I think it's something that is feasible and is worthy of further consideration.
Yeah, and it was interesting. In one of the very early rounds, it must have been in April, Bruce, way back in April, Paul Benninger from Mass General was starting to look at proning for EMS. And then I see, I mean, there's in the chat, there's a really, I mean, I think very healthy discussion. You know, if you got a 10-minute transport, does it make sense to try to prone? And then also the interfacility transfers. Gosh, to me, I mean, I just think about my previous roles in being medical director for one of those. How could you not continue proning if you're being transferred from an emergency department? Yeah, I mean, it just doesn't make sense to like discontinue it if you can do it. And the other part, I mean, I think the diversity in terms of our EMS system in the nation with, you know, private, public sector, voluntary, how has training for EMS with reference to proning, what is appropriate, what's not appropriate in terms of like, you know, interfacility versus 10 minutes or so. Bruce, I think this is like a topic for EMS rounds. Yeah, I mean, it's one of those that has emerged, but we're not there at all. It's like convalescent plasma. Well, we were there, then we're not there, and it's like this work in progress. So, yeah.
Rick, there's a lot of feedback in the chat, probably 10.
There sure is.
Yeah.
Yeah, open up a can of worms. That's just fine. That's what the rounds are all about. So, all right, let's go to the next poll question. Next ones are pretty simple. Okay, switching gears. Clinicians can get the flu vaccine through our organization. Now, not yet, but by October 1st. Doesn't plan to provide flu vaccine to providers, don't know. Wow, these results are flying. All right, like 5 more seconds. All right, let's stop there. 56% of you voted. Thank you. 23% said now. 47% not yet, but by October 1st. 3% does not plan to provide flu vaccine to providers. All right, thank you very much. Next. Which of the following is true? I got my flu vaccine. I plan to get my flu vaccine. I don't plan to get a flu vaccine. Let's keep going with this. A lot of you voted, 61% have voted. And just for awareness, I should have said it at the top. I try to remember at the top, but frequently forget. We don't identify individual responses. They're aggregated responses. So your individual responses, and we don't look for those. All right, another 5 seconds. All right, let's stop there. 8% has gotten the vaccine, 85% plan to, and 7% don't plan to get a flu vaccine. I think those results speak for themselves. Next. Our organization's plans for administering COVID-19 vaccinations are ready now, are being developed. Our organization doesn't plan to administer a COVID vaccine, and then don't know. I think after this, there are 3 more. And then Ivor, after we get done with the polling, we'll go around to Vikram and Bruce if they're able to stay, realizing people have like the 1 o'clock appointments and all that good stuff and clinic, et cetera, et cetera. And then Ivor, you get the last word, okay? All right, 5 more seconds. 58% of you voted. All right, let's stop there. Are ready now, 4%, are being developed, 24%, 5 that don't plan to administer COVID vaccine, and then 67% don't know. Okay, great. Thank you. Next. All right, this one, I'm going to do these same 3 questions. There's 3 questions here in a row. I'm going to be repeating the same questions for EMS and for emergency department rounds too. So I really want to try to limit these responses to critical care providers or leaders. So those of you in critical care, okay? And then there's a last response, I am not a critical care provider or leader. So and recognizing there are a lot of those on these rounds. So please respond so we can get a really good response to this. Since August 1st, in general, the mental health of our critical care staff seems to be better, same, or worse. Got about 55% of you voted, another 5 seconds and we'll stop. It's a really important issue that we've talked about on many, many rounds and don't want to lose it. All right, 59% of you voted. Thank you, and let's see the results. %9 better, 13% same, 12% worse. Thank you. Let's do the next one. Okay, this one is same question, again, focused on critical care providers, leaders, and this is about fatigue. Since August 1st, in general, fatigue of our critical care staff seems to be less, same, more, and then if you're not part of that population. Yeah, 54% of you voted. We're getting close, another 5 seconds. All right, let's stop there. 4% said less, 9% said same, 19% said more. Thank you. And then I think this is the next one is the last one. Okay, this one's complacency. And as we have discussed during rounds, this fine sort of like separation between, they're connected, but the nuance between fatigue and complacency, we've talked a lot about, particularly in the past few weeks. Give another 10 seconds. Yeah, 52% voted. All right, let's stop there. Thank you. 53% voted, less 7%, same 16%, more 8%. Thank you. We'll do, we're going to do the same, those 3 questions for both EMS and the emergency department as well. Thanks very much. Really helps get a finger on the pulse of where we are right now. So with that, let's take the poll down, and I'll go to Dr. Ribner. Any questions, comments before we close out?
So again, thank you to Dr. Douglas for an excellent presentation. And just to remind us, this is an infectious disease which has been with us for all of 8 months. And even though we've learned a tremendous amount and are continuing to learn, probably to mirror his comments, in 6 months' time, we will be doing everything differently and hopefully with better outcomes.
Thanks, Bruce. Still very much a new disease. Totally agree. Totally agree. Vikram?
Thanks, Rick, and thanks, Dr. Douglas. Fantastic presentation. For the rest of our attendees here, like Dr. Douglas mentioned, prone aggressively, prone early, and have dedicated proning teams to do this for you. If your nurses and respiratory therapists and physicians are too busy with other patient care, you might want to reach out to your orthopedic surgeons who pronate in the ORs quite frequently, to your neurosurgeons who pronate in the OR for their spine surgeries. We did that in New York when we had a supply-demand mismatch. And you'll be happy to see that you'll get a lot of help from people who don't work traditionally in a medical ICU. Thank you.
Thanks, Vikram. Ivor, last word.
A word of respect and appreciation to the people that do the work in ICUs. Doctors hang around. It's the unexhausting efforts of our nurses, therapists, social workers, environmental care services through this pandemic. I do have serious concern about the questions you raised. Proning, I think Dr. Mukherjee has covered exactly the issue. And that is that our institutions are under huge stress at the moment. They're under stress to provide service, they're under stress financially, and this is just the beginning. I think this issue of complacency, fatigue, burnout, and negative affect amongst our providers is of such substantial concern that the last thing we can afford is complacency. At the same time, it's a very natural response, and I challenge each of us in our own environments to bring a measure of emotional intelligence to the table and understand when we ourselves are both the victims of complacency and fatigue, and use that as we inspire others to recognize the reality of this experience, the fact that we're in for a tough winter, regardless of which state you're in, and the real imperative to just do your best with usual care therapies and avoid pandemic exceptionalism. I think the last thing that we can afford as a community is to start doing weird and wonderful things on a regular basis. Again, my most sincere thanks for the opportunity to visit with you.
Ivor, thanks very much. Dr. Strominger, anything before we close out?
Just thank you, Ivor. Thanks, Vikram, Bruce, Rick. It was a great discussion.
Yeah, I echo that. And the participants, you keep coming at us with both the chat and the QAs and the participation in the polling. It's these results, you get to see them, we get to see them. I mean, it's really important to see where we are, and we have a lot of challenges out there. I do want to also, in addition to the participants, when I talk about the participants, I saw there were a few things in the chat around, like we still didn't have power and so forth, so on. I just want to recognize there's a lot of people doing double disasters, both a pandemic and a wildfire and a hurricane and a protest. And that's a lot. That's just a lot. And so for participants that are actually dealing with that, or your fellow colleagues, thinking about all of you, and yeah, we had rounds on all those before, but it seems like doubling down on disasters seems to be the topic of the day, which is really horrifying, quite frankly. For Vikram and Bruce, thanks so much for joining us. And Ivor, really great presentation. Obviously stimulated a lot of great discussion, not just among our panelists, but in the chat and the QA too. I do think, back to, as Bruce put in the chat, we will plan on rounds on the EMS proning piece, because it obviously continues to capture a lot of not just question, but debate. And it strikes me EMS people talking to themselves about this is probably inadequate. So maybe be tapping back into some of you to help with that discussion, because quite frankly, you've got probably more experience than anybody else does with this. So with that, thanks all, and take care of yourselves. Bye.